Good evening, colleagues. Welcome to this weekend's tutorial. I will start, others will join us because of time. It's exactly 5 minutes after the hour. So today we'll be looking at a very important topic, chronic obstructive pulmonary disease, especially as it relates to us in the ICU. And many of us, we encounter them in the OR. So we're going to be looking at a clinical scenario as our custom is. All right, Mr. John Sibomona, age 67 years old male with a long-standing of COPD, gold stage D. Is hypertensive, former heavy smoker, used to smoke 40 pack years, quit 5 years ago. He now presents to the emergency room with worsening shortness of breath, productive cough with green sputum for the past 3 days, increased use of rescue inhaler with little relief. He reports feeling fatigued with intermittent wheezing and chest tightness. On arrival, his vital signs are heart rate of 110 beats per minute, respiratory rate of 30 cycles per minute, blood pressure 125/85 millimeters of mercury. SpO2 is 85% of room air, temperature 37.8 degrees centigrade, ABG pH of 7.28 with a PaCO2 of 60 millimeters of mercury and a PaO2 of 55 millimeters of mercury. His bicarbonate is 20 milliequivalent per liter. So on physical examination, there's use of accessory muscles of respiration. You can hear diffuse expiratory wheezes, diminished breath sounds bilaterally. Patient is cyanotic and confused with a Glasgow Coma scale of 13/15. So the first question, what is your diagnosis? What are the initial steps in managing this patient? What will be the indications for intubation and invasive mechanical ventilation? How will you adjust pharmacological management for a patient in COPD exacerbation? Is there any role of non-invasive ventilation in this case? What complications should be monitored in the ICU for a patient with severe COPD exacerbation? And lastly, how will you monitor its progress in the ICU? So the floor is open. Can we have anybody try to take a go at this? Anyone, quickly. Like our custom is, let's just quickly discuss this case. Anyone? CJ, you want to say something? Who is there? Anyone? I'm sure we must have seen a similar case before, so let's try. Even if we're wrong, not perfect, we correct ourselves. We're here to learn. No one? Aliyu, Anfosinia, where are you guys? Chris from Namibia. Everybody's quiet,
yes,
guys. John Pierre, John Paul.
Hello?
John Oyedele, yes, please go ahead, sir.
Yes, good evening, Prof.
Good evening.
Yes, based on the clinical scenario, the person is known with COPD, so currently they are presenting with the acute exacerbation of the COPD, most likely.
Please, can you increase your volume, please? The volume of your mic.
Can you hear me now?
Yes, please, yes.
Yes, so I'm saying the patient is known with COPD, so currently presenting now with the acute exacerbation of the COPD,
Yes.
most likely secondary to community-acquired pneumonia.
Good, good. So acute exacerbation from the ABG, what do you think?
The ABG, the pH is 7.28, so the patient is acidotic. PCO2 is elevated at 60. Normal range is 35 to 45. So there's a problem with the respiratory system because it's not able to compensate for the acidosis. It's a respiratory acidosis, and the PO2 is low. And the bicarb is 28, which is between 22 and 26. So more or less, still try to compensate, but still too early. So basically, it's a respiratory acidosis not yet compensated.
Yeah. So holistically, this patient is in respiratory failure.
Yes.
Secondary to, most likely you said it, the patient has productive cough with green sputum. So most likely the patient has a communicable acquired pneumonia. And so this patient is in acute respiratory failure, both hypercarbic and hypoxic respiratory failure, secondary to exacerbation of COPD from community acquired pneumonia. Correct. So what will be your initial steps in managing this patient? You are the first person this patient is seeing.
So in this case, we'll start with is it the emergency unit? We'll start with our usual AC approach. So we ensure the airway is patent, give supplementary oxygen, but not too much, just to maintain the saturation between 88 and 92. Ensure there's a IVI cannula in situ. Is a hypertensive. I see the blood pressure is still acceptable. Give a start dose of, take your sputum, give start dose of antibiotics, hydrocortisone, and nebulize the patient, preferably ipratropium or salbutamol nebulization.
Great, great. Anyone that can come in, you can have your inputs. So this patient, what will be the indications for endotracheal intubation and invasive mechanical ventilation? Or is there
In
any
terms of
role
intubation,
of non-invasive ventilation in this patient?
yes, with COPD, preferably non-invasive, since you end up, if you intubate them, you might struggle to extubate them in ICU. So try of CPAP, while adjusting the PEEP and to try to ventilate the lungs while also nebulizing the patient as well.
So what will be the indications for intubation in this patient?
So if the trial of the non-invasive is not successful in terms of patient become centrally cyanosed, and the CO2 keeps accumulating, so you repeat the ABG. If the CO2 is still rising, then you might need to do invasive ventilation, as well as the acidosis is worsening as well, with clinically patient not coping well on the non-invasive ventilation.
Beautiful,
And also
good.
decreased level of consciousness also, yes.
Yes, good. You are so much in line. And look at the GCS is 13 now, but patient is confused. With rising PaCO2, the patient may become more unconscious. So that may also be an indication to secure the airway. Good. So how we adjust pharmacological management for a patient is for this patient in acute exacerbation of COPD secondary to communicable acquired pneumonia. You mentioned some things. So what are the pharmacological adjustments you're going to do for this patient?
So you can try inline nebulization, and then with ipratropium, salbutamol, hydrocortisone steroids because it's an acute exacerbation, antibiotics because the change of the color of the sputum, but you still take the sputum to check the MCS, but you can give a broad spectrum antibiotics just to do the antibiotic stewardship, then later narrow it down. And yeah, oxygen therapy. And yeah, I think that's it for the acute phase.
Beautiful. Will you admit this patient to ICU?
Definitely I would, because it's 67 and it's an acute exacerbation, so we can still correct a lot of things. So ICU would be ideal.
Okay. What complications will you monitor in the ICU?
COPD patients, as we know, there's usually air trapping. So there might be risk of if you give too much pressure, it can cause barotrauma or pneumothorax. Actually, can also happen. And then those are the main ones I'm thinking of currently.
Great, great, great. Thank you, Dr. Yedele. Thank you. How will you monitor his progress in the ICU? You have admitted this patient. How will you monitor how well your patient is doing on your scheduled therapy?
So while on the treatment, I will be trying to over the day wean off the ventilator. So I also see in terms of how is it responding, or does it need high pressures or high ventilatory support, and also in terms of the vitals as well. We do regular ABGs to see if they are improving in terms of the acidosis, and clinically, and then from blood tests as well in terms of clearing the infection, because it's pyrexic, so most likely there's an ongoing infection. And then, so yeah, basically the need of the ventilation to be able to wean it off, and then the ABGs will guide as well. And clinically, the wheezing resolves, and yeah.
Beautiful, beautiful. Thank you so much, Dr. John Oyedele. You have actually given us the presentation. But for the sake of scheduled lectures, we'll still go ahead. Well done. Thank you very much. I
Yeah,
bet
thank
you are
you,
not a
Prof.
trainee.
No, no, I'm in internal medicine, so that's why we see it a lot.
Yeah, because none of my trainee, all my trainee became tongue-tied. My good, Chanceline, you want to say something? Okay. All right. So thank you so much, Dr. Edele. Appreciate that. I didn't know that we have internal medicine guys join us. I thought it's just anesthesia and critical care. We really appreciate your coming on
That
board,
was,
Dr. Edele.
yes, thank you, Prof.
I hope the lectures have been beneficial to you too.
No, definitely, because I was doing ICU rotation, so that's where I joined the group. So I'm learning a lot.
All right. Thank you so much. All right. So let's go on. Some of the questions raised here will be answered in the course of the presentation. And permits me to recognize Dr. Doreen Mashaba, the registrar of the College of Anesthesiology of East Central and Southern Africa. And I also saw my trainer, Professor Kola Wale, is here this evening. Welcome, sirs, and welcome, ma. I appreciate you. Professor Kola Wale was one of my trainers when I started residency in Ilorin. Welcome, sir.
Thank you, Dr. Toby.
All right, so let's move. All right, so this will be our learning objectives. At the end of the lectures, we would understand the pathophysiology of COPD, and we'll also try to identify the triggers for ICU admission, because it's not all COPD patients that are admitted. All right. We'll also, okay, yes, Dr. Maru Kamaru, okay. Will perform you should be able to perform a comprehensive initial assessment in the ICU, including history, physical exam, ABG interpretation. Be able to apply evidence-based approaches to oxygen and ventilation therapy. You should be able to differentiate between the indications for NIV and invasive mechanical ventilation with specific protocols. Especially, we're going to be looking at the good guidelines in the clinical practice, from assessment to staging and long-term management of COPD. All right, we'll follow this outline. So, what is COPD? It's a progressive inflammatory disease of the lungs, which is characterized by airflow limitation that is not fully reversible. All right, it's a progressive inflammatory disease of the lungs that is characterized by airflow limitation that is not fully reversible, broadly classified into two: chronic bronchitis or bronchiolitis in the younger age group and emphysema. Now, it concerns us because one of the reasons why this lecture has been held is because many COPD patients develop acute exacerbation requiring admission to the ICU, all right? And many factors affect the outcome of this patient. And one of the most important factors is the acid-base disorder, as we saw in our clinical scenario. Epidemiology, COPD is primarily present in smokers. Our patient for clinical scenario was a previous chronic smoker, 40 pack years, just stopped smoking about 5 years earlier, all right, before presentation, all right, and it's also common in the elderly, above 40 years old, and is now regarded as the third most common cause of morbidity and mortality worldwide. All right, it's important for us to quickly look at the major difference between obstructive and restrictive pulmonary disease. All right, definitely we'll come across one of these things in our practice. So obstructive pulmonary disease impairs expiration, all right, while restrictive disease impairs inspiration. This is the critical difference between these two. All right. So it impairs expiration, obstructive, while restrictive impairs inspiration. Examples of obstructives include asthma and COPD, like we know. And because of impairment of expiration, the obstructive diseases reduce the forced expiratory volume and the forced vital capacity. And what we normally do is the FEV1 over FVC ratio. All right. But vital capacity may not change, may actually increase because of the increase in the AP diameter of the chest. All right. Restrictive examples include the pneumonia, pulmonary fibrosis, all right, otherwise known as the black lung. All right. They reduce volume, but do not affect FEV1, FVC ratio. Now, on the slide on this on the right of the screen, you can see the normal lungs, all right, the FEV1 and FVC, the full vital capacity, forced vital capacity. In obstructive, both are reduced, all right, while in restrictive, there is no reduction in this, all right, but it's just all right, a reduction in volume, but not the FEV1 over FVC ratio. All right, so this is just the basic difference between obstructive and restrictive pulmonary disease. We're going to be looking at so many mnemonics. I tried to break it down. So most of the mnemonics here, the COPD. So we're looking at the pathophysiology. Remember COPD, especially the trainees. All right. So if you're asked to write something about pathophysiology of COPD, just write COPD. The first one is C, chronic inflammation. All right. In COPD, there's chronic inflammation involving the airways, the lung parenchyma, and pulmonary vasculature. All the clinical presentations you will see in COPD, all right, either stable COPD or acute exacerbation of COPD, these are the three, pathophysiology that accounts for them. All right, the process is thought to involve oxidative stress and the imbalance between the protease and antiprotease enzymes. Oh, there's an obstruction of the airways. All right, the inflammatory response and obstruction of the airway cause a decrease in the forced expiratory volume in 1 second. Please, can you mute yourself, please? Okay. So the obstruction of the airways leads to a decrease in FEV1, and tissue destruction leads to airflow limitation, and this one will result in hypercarbia. Carbon dioxide accumulation, like we saw in our patient PSU2 was 60-something. The P, there's parenchymal damage, which resulting in loss of alveolar attachment, leading to decreased gas exchange. That's why you have hypoxemia in this group of patients. In our clinical scenario, the PaO2 was 55. Then the D is dynamic hyperinflation of the lungs, which is due to air trapping. Dr. Oyedele made mention on it. And this also will guide our therapy in terms of the amount of PEEP that is required, because most of them already have auto PEEP with air trapping from collapse of the airway during expiration. All right, so the inability to fully expire at the end of expiration will cause hypercarbia. And as this progresses, all right, we have pulmonary hypertension, all right, which will lead to right heart failure, all right, and these are some of the things we look at in the ICU, all right, as complications of COPD. Pulmonary hypertension occurs due to diffuse vasoconstriction from hypoxemia. We're going to look at the response of the body to acute exacerbation of COPD, and that's when you will see the hypoxic vasoconstriction that occurs in the pulmonary vasculature. All right, acute exacerbation of COPD are common, all right? Common indications for admission to the emergency room and the ICU. And they're usually due to triggers, all right? Both infectious and non-infectious triggers, as we're going to look at them, all right? So increased inflammation and air trapping often require corticosteroids, either inhaled steroids or systemic steroids, and bronchodilator treatment. All right, so I hope you can see these slides. So noxious particles and gases, all right, will lead to oxidative stress like we mentioned before, and all this will lead to inflammatory process accounting for the COPD pathology. All right, the noxious particles can also cause lung inflammation, and we see the host factors come to play here, host factors in terms of age and comorbidities. All right, genetic factors like your alpha-1 antitrypsin deficiency, all right, leading to imbalance between your proteases and antiproteases, which can also cause COPD. In all of these, there's usually a repair mechanism that starts on. This can lead to a fibrotic lung. All right, so this is just the normal, distal airway, the alveoli. All right, so here, there's normal airflow represented by 3 arrows. All right, these are the smooth muscles. So the alveoli is of normal volume and normal structure. But when there's an obstruction, all right, you can see that there are 2 arrows here instead of 3. So there's an obstruction of airway flow, and this will lead to alveolar hyperinflation, hyperinflation, all right, which will lead to distension of the alveoli, loss of elasticity, impaired gas exchange, and all that. And this smooth muscle contraction and contractility, and that's why you use antimuscarinic, all right, as one of your bronchodilators to relax smooth muscle contraction in this patient. In all of this, as the process goes on, there's airway remodeling and fibrosis that occurs secondary to chronic inflammatory process. Okay, like we mentioned before, COPD can be divided into chronic bronchitis and emphysema. All right, and chronic bronchitis, like we learned in medical school, is defined by the presence of a productive cough on most days for 3 consecutive months, occurring for at least 2 consecutive years. So it's a chronic condition. Predisposing factors are the COPD, like I mentioned. We have cigarette smoking, occupational exposure, all right, recurrent pulmonary infections, and you have familiar factors like your genetic factors. Now note that COPD due to chronic hypoxemia will lead to erythrocytosis, all right, and pulmonary hypertension from pulmonary vascular constriction, and eventually, like I mentioned before, you have your pulmonale. Hypercapnia, most of the patients are chronically cyanotic, and that's what we call them the blue bloater. So remember that in chronic bronchitis, you have the 4H. We have hypoxemia. We have pulmonary hypertension. You have heart failure and hypercapnia or hypercapnia. All right, these are the 4 things always remember at the back of your mind as the consequence of chronic bronchitis. Okay, I mentioned this several times. All right, risk factor. Let's move on. All right, in emphysema, all right, emphysema is characterized by an irreversible enlargement of the airways distal to terminal bronchioles with destruction of alveolar septa. All right, now this is what we know as lung parenchymal damage. All right, like we talked about the pathophysiology. Most of the times, emphysema is diagnosed with your CT chest. All right, you'll see the enlargement of the airways distal to the terminal bronchioles, and you will not see alveolar septa. Differentiating the different alveoli. Apical emphysema changes are normal, but clinically significant consequences of aging, and that's why we say that it's common among elderly people. All right, significant emphysema is more frequently related to cigarette smoking. All right, but in cases where you have deficiency of homozygous deficiency of alpha-1 antitrypsin enzyme, which is a protease inhibitor, all right, the work of the alpha-1 antitrypsin enzyme is to prevent excessive activity of proteolytic enzymes, especially elastase in the lungs. When you have a deficiency of alpha-1 antitrypsin enzyme, you have an imbalance between proteolytic and antiproteolytic activity, and there will be excessive parenchymal damage of the lungs from, uninhibited activities of your proteolytic enzymes, especially elastase in the lungs. And this is more common in emphysema, and this can occur at any age. So when we see emphysema in younger age, we must do genetic typing to rule out homozygous deficiency of alpha-1 antitrypsin enzyme. So risk factors for emphysema, as usual with smoking, all right, we said it before, and maybe due to relative imbalance, we mentioned this before, all right. When emphysematous patients are dyspneic, they tend to delay the closure of the small airways by forcing their lips, so we call it pink poppers, all right? They're not as cyanotic as the blue bloaters of chronic bronchitis patient, but they pause their lips, all right, to create an auto-peep to ensure, or rather to prolong the closure of the distal airway. So we call them pink puffers. All right, so there are differences. I like asking these questions from my students, the difference between chronic bronchitis and emphysema. You can go through this when you see, when you receive the slides. Now, normally the body tries to compensate, all right, for some of the pathophysiological changes in COPD. And one of the common things we see is the acute or chronic hypoxemia in COPD patients. So when they become cyanotic or hypoxic, all right, there's a secondary effect, which is hypoxic pulmonary vasoconstriction. And this is an attempt by the body to try to maintain the ventilation perfusion ratio by localized vasoconstriction in the area of the lungs that are not as oxygenated as the rest. So tries to maintain vacuum mismatch. But know that in this extent, there's a reduction the ability of the patient to expel carbon dioxide. So this leads to hypercapnia, which over time leads to acid-base disorders and a shift of the normal respiratory drive to hypoxic drive. Let me explain this. You remember your respiratory physiology. Carbon dioxide is the potent stimulator of the respiratory center. All right. This goes on with your, elaboration of your hydrogen ion. All right. So when there's chronic hypercarbia, the what's it called? The hypercarbic drive for respiration is lost, and there's a shift to hypoxic drive. All right, and that is why there's what we call the cautious use of oxygen therapy in COPD. All right, and a lot of times people have said that don't give too much oxygen so that you don't knock off the hypoxic drive. Yeah, that is true, but the impact of oxygen therapy in knocking off hypoxic drive is not as strong as the impact on carbon dioxide accumulation. So oxygen therapy reduces ventilation and, more importantly, leads to excessive accumulation of carbon dioxide. So what we are more afraid of is the excessive buildup of CO2, which has systemic effect. Now, in COPD patients, the kidneys, like we can see, the bicarbonate in this patient was 28, which is a little more, all right, trying to compensate, although it's still uncompensated. What the kidneys try to do is to retain bicarbonate in order to neutralize the acidic pH caused by excessive accumulation of carbon dioxide. Now, you can imagine, okay, all right, this is where I'm coming to now. You can imagine patients with renal failure. All right, a patient in renal failure, the kidneys cannot reabsorb bicarbonate to compensate for the chronic respiratory disorders or respiratory acidosis. Over time, you have mixed respiratory metabolic acidosis causing dangerously low pH levels. The mortality, patients with AKI, chronic kidney disease that comes down with COPD or exacerbation of COPD, will have higher mortality because of this. What I was talking about before was oxygen therapy can lead to an acute increase in CO2, but the effect of oxygen hypoxic drive is relatively small. Over time, we have always been talking about don't give too much oxygen so you don't knock off the hypoxic drive. Yes, but more importantly is the rise in CO2 with dangerous systemic effects that we should be more worried about. All right, so clinical presentations, chronic cough, obstruction of the airway, you have wheezing, all these are COPD, like I said, all the mnemonics, production of sputum. All right, in our patient clinical scenario, we talked about the patient had a production of greenish sputum. All right, and the patient becomes dyspneic with increased work of breathing. All right, so there's need for us to differentiate between COPD and asthma, all right? And one of the things that COPD lacks nocturnal symptoms, also lacks the annual variability, is usually not associated with allergies like asthma, and is persistent and progressive. Remember the definition. There's what we know as irreversible airway obstruction. All right, in asthma, bronchodilator therapy can have a completely reversible airway obstruction, which is not the same with COPD. It's persistent. Once it sets in, it's a progressive airway disease. Now, note that there are systemic manifestations of COPD. COPD, like we mentioned, affects every part of the body. And I put a mnemonic here, COPD wheezing. So there's central cyanosis. Or there's edema in the lower extremities, which is often due to your right heart failure, your cor pulmonale. There's prolonged expiration, all right, digital clubbing, all right? Remember internal medicine rotation, Dr. Udele, you know that so one of the causes of digital clubbing is COPD, wheezing, hyperinflated lungs, all right? And we have extremity muscle wasting. We have the barrel chest, all right, which is due to increased AP diameter of the chest. There's zealous use of axillary muscles. There's increased work of breathing, all right, nasal flaring and gasping for air. So if you're asked, trainees, if you're asked what are the systemic manifestations of COPD, I've broken it up for you, all right. The mnemonic is COPD wheezing, all right. C stands for central cyanosis, O edema, P prolonged expiration, all right. Digital clubbing, wheezing, hyperinflated lungs, and especially I'm going to show you. All right, yeah, this is the slide that shows you the barrel chest. All right, this is the normal chest with a normal AP diameter of the chest, but because of hyperinflation, all right, from accumulation, obstruction of or limitation of airflow, you have AP diameter. So this is characteristic of COPD patient. Now, if you ask in steeplechase, they bring this for you and they ask you what respiratory condition can account for this chest deformity. Just know that COPD, all right? There's an increase in the anterior posterior diameter of the chest, also known as the barrel chest. All right, so I'm going to talk about the Global Initiative for Chronic Obstructive Lung Disease, the GOLD Initiative. All right, it was initiated by WHO and the National Heart, Lung, and Blood Institute. All right, this initiative has the responsibility of monitoring COPD, all right, drawing guidelines, protocols for management, and the overall aim is to reduce COPD, the incidence of COPD, especially exacerbation of COPD. And we're going to go through these good recommendations as we go on in the course of this lecture. Okay, so one of the things, the GOLD criteria, the GOLD initiative is to categorize the severity of COPD. All right. Now, for you to make a diagnosis of COPD, your FEV1 over FEVC or FEV1 FVC ratio should be less than 0.7. All right. Then the severity is based on the first expiratory volume in 1 second. So GOLD 1, remember we said that our patient in clinical scenario is GOLD 4. It means that he has a very severe COPD with his FEV1 less than 30% predicted. So that patient, GOLD D severity, all right, has a very severe COPD. All right. So for patients, COPD patients with their FEV1 still greater than 80% of predicted volume, they are mild. Moderate is between 50 and 80. All right. While severe is between 30 and 50. For very severe, the FEV1 is less than 30% predicted. All right, so this is what we're talking about. The GOLD classification also groups patients from A to D on the basis of symptoms and exacerbation. All right, now we're going to get to that. So group A have low symptoms with low exacerbation risk. Group B high symptoms, low exacerbation risk. Group C has low symptoms with high exacerbation risk, while Group D, they have high symptoms and a very high risk of acute exacerbation. All right. Another way to assess and monitor COPD is by this questionnaire that was developed by the British Medical Research Council, also known as the Modified MRC questionnaire. All right, it is used to assess the severity of breathlessness in COPD patient. So when you have MRC grade 0, all right, the patient says, I only get breathless with strenuous exercise. You tick it. Grade 1 is, I get short of breath when I'm hurrying, all right, on the level of walking up, or on the level of walking on a slight hill, take that bus. Grade 2, I get shortness of breath, therefore I walk slower than most people of my age, or I have to stop for a breath when I'm walking on my pace on a level, that patient has MROC of grade 2. Grade 3, and when the patient says, I stop for breath after walking about 100 meters, all right, or after a few minutes on the level, all right. Grade 4 is when a patient is too breathless to leave the house, or even breathless with normal daily activities like dressing and not dressing. So the British Medical Research Council questionnaire helps to assess the severity of breathlessness in COPD patient. The second assessment is the COPD assessment test, the CAT test. Okay, all right. And this describes the quality of life of this patient. So when a patient says, I never cough, or I cough all the time, I never cough zero, all right, so I cough all the time. Remember, chronic bronchitis is defined as presence of cough for most days for 3 months, for a consecutive of 2 years. All right. I have no phlegm, zero, but my chest is always completely full of mucus or phlegm. That's fine. All right. And in MROC, you grade from 0 to 4. While in CAT assessment, that's COPD assessment test, you grade from 0 to 8. Okay, it's here. So the GO protocols, this is how to approach a patient with COPD according to the GO protocols. All right, you want to assess symptom, the level of symptom. I've just mentioned that to you. You use the Modified Medical Research Council dyspnea scale. All right, it classifies breathlessness on a scale of 0 to 4. Then the COPD assessment test, all right, evaluates the impact of symptoms on activities of daily living, all right, and you classify it by 0 to 8. Then you want to look at the exacerbation history. Patients with high symptoms and high risk of exacerbation will fall into group D. So assessment is key, the first one. Then you want to classify your patient after assessing them into the groups we talked about. The assessment will determine the level of intervention, therapeutic intervention. For patients with low symptoms, with low exacerbation risk, you want to give them short-acting bronchodilator agents. All right? All right. For patients with high symptoms and high exacerbation, you want to give them long-acting muscarinic antagonist, or you want to give them a combination of long-acting muscarinic antagonist and long-acting B2 agonist. All right. For these patients in group D, you want to also add your inhaled corticosteroids if exacerbation persists. So the GO criteria tells you, classifies your patient on the basis of symptoms assessment and the severity of symptoms, which will help you to determine the level of therapeutic intervention. For treatment strategies following the GO protocols, all right, pharmacological interventions is grouped into pharmacological and non-pharmacological intervention. All right, your short-acting beta agonist, for instance, your salbutamol is given for quick relief. Dr. Edele was talking about that as part of his initial approach to the patient. All right, then you can go to the long-acting beta agonist or the long-acting muscarinic antagonist for regular use to improve lung function and reduce symptoms. Inhaled corticosteroids for patients with frequent exacerbation, this most likely will be combined with your long-acting beta agonist. Non-pharmacological intervention, cessation of smoking. Remember that in our clinical scenario, the patient has stopped smoking 5 years earlier to presentation, and this is essential for all patients. Like we said, the cigarette smoking is the cornerstone for the pathophysiology of COPD. Pulmonary rehabilitation, structured exercise and education program, and vaccinations with annual influenza and pneumococcal vaccines, especially for, we're going to look at that one a little more. Management of exacerbation, all right, number one is key to promptly identify cases of exacerbation in patients with COPD, all right, and we're going to dwell more on that. You know, I like mnemonics. I put it at DSP. All right, you want to look at dyspnea. Okay, you want to look at sputum production. Okay, and you want to look at these three, the presence of cough. So identification of exacerbation when a patient comes, is this patient in acute exacerbation or COPD? Treatment. Increase your bronchodilator use. Dr. Yedele, you remember? How do you adjust your pharmacological agent, all right, for this patient? You want to increase your bronchodilator use, either dose or frequency. Remember that we said in that patient, the patient had reduced relief, increased inhaler use. If you look at the story, the history that was presented in that patient. So you move to systemic corticosteroids, all right? Inhaled corticosteroids is for short period. You want to move to methylprednisolone. Antibiotics is indicated, like you rightly mentioned, Dr. Yedele, all right, if bacterial infection is suspected. So investigations, that's the gold criteria. We're going to see more of that as we go on. But let's look a little about the investigations. The first one is the pulmonary function test, like we mentioned. So FEV1, FEVC ratio less than 0.7 confirms an obstructive pattern. All right. And what you do, you can do bronchodilator testing. When the FEV1 increases by 12 to 15%, and FEV1 volume is about 200 ml, it shows an obstructive lung problem. Then we have the diffusion capacity of carbon monoxide. Most COPD patients have very low DSCO, all right? And this also will mirror impaired gas exchange. So when a patient with COPD has very low diffusion capacity of carbon monoxide, it correlates more with severe disease pattern and a poorer diagnosis. Asthma patient, this another use of diffusion capacity of carbon monoxide is to differentiate between COPD and asthma patient. Asthmatic patients usually have normal to near normal diffusion capacity of carbon monoxide, while COPD patients, especially those with emphysema, always most often have reduced diffusion capacity of carbon monoxide. Laboratory testing should focus on the presence or absence of infection. You want to look at the HB for patients with chronic hypoxemia. You have polycythemia, all right? You want to look at the alpha-1 antitrypsin level, all right, as a cause of COPD. Chest X-ray, hyperlucency, and hyperinflation. ABG, PaO2 less than 60 shows hypoxic respiratory failure, and PaCO2 greater than 60, it shows hypercapnic respiration, and respiratory failure. And this can also be used to differentiate between chronic bronchitis and emphysema. All right, when you have a PaO2, all right, less than 60 millimeters of mercury with elevated PaCO2, it shows you chronic bronchitis. So you have, hypoxemia. In emphysema, that's what we call them pink puffers, all right? The PaO2 usually greater than 60, and they have a normal PaCO2. So that shows you emphysema. Chest CT, may show you centrilobular emphysema with loss of septors, lobular septors. You may also be able to see some bullae, especially in these pleural regions. There's what we call the 6-minute walk test, all right? The test usually performed indoors on a flat and straight surface. So it is used to assess the submaximal function capacity of the patient. The length of the airway is usually about 100 feet. And this test measures the distance the patient can walk over a period of 6 minutes. All right, does the patient get breathless? What is the level of comfort the patient experiences during this 6-minute walk? All right, so these are differential diagnoses. We'll not talk about that. All right, so in all of these treatments are broken down: COPD cessation or smoking, oxygen therapy, or you give about 1 to 2 liters per minute. If VO2 is less than 55, all right, you want to also try to give non-invasive ventilation. We always try to start with non-invasive ventilation, but when we have issues with failure or increasing PaCO2, like Dr. Idili mentioned, or the patient becomes, more unarousable with decreasing level of consciousness, right? You want to intubate. So another thing is that you want to assess for the need for respiratory support in this patient. So for patients who are fatigued, struggling to breathe in spite of treatment, in spite of your bronchodilators, patients who have had extended trials of NIV, patients, you continue to monitor the HP, the heart rate, respiratory rate, and all that, and you reassess this patient every 30 minutes until the patient is stable. So these are the patients you want to do NIV for. Dr. Idili, I disagree with you with your mode of ventilating this patient NIV. All right, what's it called? Bilateral positive airway pressure is preferred in this patient because it produces both inspiratory positive airway pressure at 10 to 15 centimeters of water, and your expiratory pressure, airway pressure, about 4 to 5 centimeters. So BPAP is usually better because throughout the respiratory cycle, both inspiration and expiration, positive airway pressure is usually provided for this patient. You start with FiO2 of about 24 to 28, and your target is to get SpO2 of 88 to 92%. All right. You want to set your respiratory rate. This is on your CPAP machine or your NIV parameters. There are some ventilators that can give NIV mode of ventilation. So you need to set it. You aim for 6 to 8 mils per kg ID body weight to prevent lung distension. Remember that this patient already have hyperinflated lungs. Inspiratory time should just be adequate for inspiratory flow between 0.8 to 1.2 seconds. All right, so when the patient begins to have impending respiratory arrest, circulatory failure, altered level of consciousness, lack of improvement after 3 to 4 hours of optimal medical therapy and NIV support, and PO2 is rising above 55 to 60, and patient is acidotic with pH less than 7.28. In asthmatic patient, you want to intubate and invasively ventilate them. Now, whether you use assist control volume control or assist control pressure control, it does not matter. All right, but the pressure control is better, especially if you aim to utilize low peak inspiratory pressure. Tidal volume is the same, 6 to 8. Lower tidal volume helps to reduce the risk of hyperinflation that we mentioned. All right, and PEEP, oftentimes I keep PEEP below 3. All right, normal PEEP for everybody is 5, but for COPD and asthmatic patients, we keep them between 0 to 3. And the reason is to avoid worsening hyperinflation. Inspiratory flow rate is between 60 to 100. Most times I keep them 100 liters per minute. And this is to quickly deliver your required tidal volume and to allow for prolonged expiratory phase. Another very important parameters you need to set is your IE ratio, inspiratory expiratory ratio. You want to give more time for expiration. So we aim for a patient between 1 to 3 or 1 to 4. Just yesterday, we had to estimate a patient, wean him of a 16-year-old patient who's been in our ICU, was in emergency room, severe asthmatic attack with loss of consciousness and all that. We actually had to put the PEEP at 0 and the IE ratio at 1.4. And patient did well. We were able to extubate the patient successfully yesterday. So these are practical ways to go ahead. All right. Complications, acute exacerbation. Quickly, my time is up now, and we still have a lot. So let's look at acute exacerbation. Let me see how many slides I have. 1, 2, 3, 4, 5. Oh, no. Okay, let me run. I think we should finish it. It's not much. So the important thing is, for us as critical care physicians, we deal with acute exacerbation of COPD. Most of the time, COPD can be mentioned as outpatient, but when there's acute exacerbation, they come to the emergency room and eventually get admitted to ICU. All right, so acute exacerbation of COPD, these are episodes of symptoms. All right, when the episodes of symptoms continue to worsen, that is your dyspnea, cough, sputum production, all right, leading to significant morbidity and mortality. And so many times this patient requires hospitalization. All right, annual influenza vaccination is recommended in all patients with COPD to reduce the incidence of acute exacerbation. So you'll read these slides as we go on. So assessing exacerbation is important, all right? And this has to do with worsening of dyspnea. You want to look at, is the volume of sputum increasing, and what is the prevalence? So that is the GSP I was talking about. So mild exacerbation is when you have one of these symptoms, either dyspnea, increase in sputum volume, or increase in prevalence. In addition to increase wheezing, increase cough, and all that. But when you have 2 or 3 of dyspnea, sputum volume, and prevalence present in a patient, that qualifies for moderate to severe exacerbation, and these patients will likely have acute respiratory failure. Like our patients in our clinical scenario, that patient is in hypercapnic and hypoxic respiratory failure, all right? And you'll find the signs and symptoms, especially the systemic manifestation. So acute exacerbation can be caused by infectious, non-infectious, and other causes, all right? The common cause of infectious cause, the common organisms, the bacterial organisms, the H. influenza, streptococcus pneumonia. And this is very important, especially in your choice of antibiotics, initial antibiotics before you do your culture sensitivity test. All right, non-infectious causes like we say heart failure patients who have an embolus, pulmonary embolism, or patients who are not adhering to their medications, or incorrect inhaler technique, all right, can lead to acute exacerbation. Factors like stress, dehydration, changes in weather, air quality changes, all these can provoke exacerbations of COPD. Assessment, you need to assess that, identify the triggers, and you commence your oxygen therapy, all right? And continuous monitoring is important. We mentioned this, non-invasive ventilation is the first line of hypercapnic respiratory failure with acidosis, a pH less than 7.35. All right. The NIV reduces the need for intubation and invasive ventilation. Like Dr. Idele said, most of the times when you place the patient on ventilator, they become ventilator dependent and it may be difficult to wean them. All right, I have a patient with lung fibrosis who has spent more than 4 months in our ICU as I speak to you. Try to wean him off on TPs, it comes back down to ventilator again. So you want to avoid invasive mechanical ventilation as much as possible. But when the patient have a pH of less than 7.25, or when your non-invasive ventilation fails, you want to aim for lung protective ventilation. with low tidal volume, 6 to 8 mils per kg at the body weight to avoid viral trauma. Bronchodilators, we've mentioned that before. Antibiotics, as the case may be. All right, you want to target antibiotics, especially with your local ecology for community-acquired pneumonia. All right, amoxicillin, carbonylate antibiotics. Then you have your azithromycin, usually a macrolide that is very useful for community-acquired pneumonia. All right, adjuvant therapies like mucolytics may help in case of excessive mucus production, adequate hydration, physiotherapy, and follow-up. All right, we mentioned all this before. This is just to give a summary. So, summary of the management of acute accessibility of COPD is COPD. All right, just go through that. Prognostic factors for COPD, presence of comorbidities. We did mention that patients with chronic kidney disease or AKI with COPD, they may not be able to compensate. They may not be able to muster enough renal compensation for their severe acidotic state. They may become oxygen dependent and may require long-term ventilation, like we mentioned. Or pulmonary function decline and dyspnea severity. So if the patient, the dyspnea is very high, MROC of about 4, all right? These are bad prognostic factors. Then we have the Bode index, all right, which is a tool that's used to determine the risk of mortality. It comprises the body mass index, obesity, the degree of airflow obstruction, dyspnea, and exercise capacity. We usually use the 6-minute walk test. The Bode index is scored on a point scale of 1 to 10, all right? And the cumulative score is correlated with a 4-year survivor. So when you have high Bode score, all right, 7 to 10, the estimated 4-year survivor is about only 18%. All right, whereas when the Bode index score is between 0 to 2, the estimated 4-year survivor rises up to as much as 80%. All right, so these are the answers to the clinical scenario. I'll quickly rush that we can end it. All right, so the initial steps in managing this patient is oxygen therapy, just like Dr. Oedile mentioned, avoid hypoxia, right, which could worsen hypercapnia. Like I mentioned before, the first step is NIV, BPAP to improve ventilation, bronchodilators, corticosteroids, antibiotics, okay? What are the indications for invasive mechanical ventilation? Worsening respiratory failure despite NIV, when the patient has reduced level of consciousness, patients become hemodynamically unstable. Don't forget that one of the consequences of chronic acidosis is arrhythmia, which can lead to hemodynamic instability. Severe acidosis, persistent pH less than 7.25 despite NIH. Complications, pneumothorax. COPD patient at risk of spontaneous pneumothorax, and you want to monitor for respiratory failure. Many of them may develop ventilator-associated pneumonia. I mentioned all of this before. How will you monitor oxygenation and ventilation? Continuous pulse oximetry and regular ABG checks. You want to monitor the effectiveness of your non-invasive ventilation. You want to monitor hemodynamic factors and response. All right, conclusion, I made it. So the management of COPD in the ICU is a complex multidisciplinary approach and is focused on stabilizing acute exacerbation, optimizing respiratory function, and preventing complications. It's very important that according to the GOLD criteria, to recognize and treat exacerbation triggers early with tailored use or cautious use of oxygen therapy, non-invasive ventilation, and appropriate adjustment of the pharmacological agents. These are key to improving outcomes. These are the references. Thank you, colleagues. I think we'll stop here. We'll wait for comments, contributions, and let me stop the recording.